How's it going, everyone? This is the Nips and Sips podcast featuring me, myself, Dr. Jeremy Boyd, and my partner in crime there, Dr. Brandon Cruz. Today, we're going to be talking about what manual therapists or physical therapists, outpatient orthopedic and sports physical therapists can do to help their clients from distance. I know a lot of us have had to convert to telehealth or virtual sessions, so figure it'd be a good time that we can kind of help people, continue the hands-on skills that we're given to the clients in the clinic, and then extend it to the virtual world per se. Definitely starting to feel that first drink there, and
Yeah. For those of you who don't know, this is our second episode we're shooting today. But yeah, Jared, well, what you were talking about, how can we add more value to our patients? Especially now in the pandemic when patients are at home, we're providing telehealth, but aside from educating them and demonstrating some exercises, what else is in your arsenal to give not only the patient value, but have them, not lose the full benefits of what they were getting. And obviously a lot of patients come for hands-on and hands-on component of therapy. It's a big component of obviously what Jeremy and I do and what we preach, how it should be a part of what you do. But via telehealth, you can't reach through the screen and touch the patient. So today we're really going to focus on, we'll touch upon some exercises and stuff, but what are some self-mobilization techniques or suggestions that we can provide to you guys that you can then bring to your patients? And that's kind of what we're going to focus on in today's episode. But before we go into that, let's talk about our drinks. Jared, so you got that nice mug with that nice porter right there.
Yeah, this is stout, actually.
Or stout, sorry. I don't know what's that for.
Tough to tell. So the nice mug, I figured we started this more in the morning. So I figured I'd have more, porters and stouts to kind of, I don't really feel like having IPAs and that sort of stuff earlier in the morning. But so this mug is from Love City Brewing, which is in Philadelphia. Awesome brewery, great scene. Really nice people there. Got some TVs and stuff. Hopefully when this pandemic is over, they can open up. I went there on a brewery tour sort of thing for my anniversary, which was great. I was like, this is a great way to spend an anniversary. So I went to 4 breweries on a bus and drank beer along the way, which was awesome. And this was one of the stops. So really cool if you're in the city of Philadelphia. I think it's one of the better Philly breweries. What I'm drinking is from you there, Brandon, for our our holiday party.
It was the trifecta's party, not Pursuit.
Trifecta party, all right.
Yeah.
And we were doing that white elephant, and you suggested I should go for one, so I definitely did, and they weren't going to mess with the boss man there. So there's a nice winter series. I've been holding on to it until my Nips and Sips got going. It's Stone Ex Coveza. I don't know if I'm saying that right, but it is freaking delicious. 8.1%. So if I start getting a little fuzzy towards the end of this podcast, you guys know why. But it's a imperial stout inspired by Mexican hot chocolate. So it's with chocolate. It's got coffee, pasilla peppers, which I didn't know what those were. Vanilla, cinnamon, and nutmeg. Taste of vanilla and nutmeg. This goes out as one of my favorite kind of stouts here. It's delicious.
Yeah, sounds great. I don't like beer, but I kind of want to try, see what that one tastes like.
Yeah, definitely want like 6 of these in a row. Be a little bit much, but the taste is killer.
And I have my usual here. I have my Buchanan's here on the rocks. Ice is kind of melting it, so now it's becoming a whiskey Scotch blend with water. But yeah, so we'll be drinking to this and talking a little PT and some self-mobs. So I guess, Jer, what are I guess, how have you been approaching this? Because I know you jumped into this before I did with the telehealth. I used my time off to learn some other things and get some other business ventures going, and catch up on some things that we wanted to do. So I've only had a few patients, but I know at least early on you were diving into the telehealth game pretty hard. So what were your experiences? How were you able to provide value, and what were some techniques that you found? I don't know if you could just talk some cases real quick to everybody.
Yeah, so I didn't really view it as a means to keep, I don't know, the finances going. I'm always patient first kind of sort of company. So I just want to keep providing care to my clients. So it was kind of free for all my trifecta clients. And if they didn't feel comfortable coming in, or there's some people that's like, I don't really think it's necessary for you, the risk reward for you to come in. I think we can treat you via telehealth. It was just, it wasn't so much incredibly different than what I was doing, obviously no hands-on and those sort of things, but um, I was always teaching self-mobilizations. I always have a belief that if you mobilize or you believe that there's something that needs to be mobilized, you should probably teach them how to do it themselves. Overall, we know the compliance and home exercise program is pretty poor. Um, but I'd at least do it for my own sake and for myself to feel better. So, but it definitely, made me think that what can drive a little bit more home, or have them do it. I can say, hey, I just, mobilized, manipulated this. This is the technique to do at home to carry you over between sessions. Now I'm just watching them do it. So that was a little bit different. And then I can kind of cue them and those sort of things. And it's definitely a little bit not ideal. Even besides just the hands-on, being able to do a manipulation or mobilization right there, but even from an exercise standpoint where I am, everything, from the most basic, like a clamshell to, a snatch. Um, I'm there trying critiquing things, either from just a form standpoint or a modulation standpoint. Hurts to do a 200-pound squat. There are certain times where I get my hands on the person, play around with their patella, or, cause force resistance to the abductors, or, change some positioning and those sort of things with my hands at first, that I can't necessarily do via telehealth. But, at least I can like ask them, all right, well, why don't you try pushing out a little bit more, change up your stance a little bit. So we have some cool case studies. I have an elite gymnast that I'm trying to work with who has a Liz Frank injury. It's tough. A couple times she's talking about, in that area, it's been a little sore and those sort of things. So I can't palpate, feel around. It's a little tough for that. But, we talk about it. We see if it's within kind of normal parameters, and then I kind of get her going, try and do any self techniques, warm up. And now we're at the point where she's doing like tumbling drills on a trampoline and stuff. So it's definitely forces you to evolve a little bit. I'm not gonna lie, I'm gonna hope for things to restore to normalcy, so I can just be like, oh, you need this sort of thing at your foot, or change up your footwear or something of that nature. But a lot of me videoing things as I see things, so I can like break it down, text it to the client, let them know. But yeah, it's kind of my experience with telehealth thus far. But what about anything from you, Brandon? I know.
Yeah. I've had a few handful, but I was gonna say I think the bright spot, we can do something like this where I've recorded the Zoom session, and then it comes down to a MP4. You can easily go in and put it on your phone. And now you're talking about Olympic weightlifting. I was treating someone who's very avid in golf and hurt their back playing golf. And he can go in his basement, swing a club, and I can now break down, I have to send it to him after a session, but I can go in and now edit the video and draw lines and stuff and send it to him, where I probably wouldn't do that in the clinic.
Mm-hmm.
So that's kind of been a nice advantage, because the
Yeah.
video's here already. I can't get in there and cue and adjust, kind of like you were saying, but that's a great alternative. You just download the video straight to your computer, put it in either your regular iPhone or video app, or download one of the other ones, Huddle or Hurdle, or there's a golf swing analysis one, whatever the case may be, and you can edit those there. Another thing I've been able to utilize is self-mobilizations, and I have ebooks that I've worked on, and I've kind of, for one reason or another, haven't really fully completed them, and this has been the time to complete them. And I've been able to send them actually to some patients, and it's like, oh, here, I've been working on this, here, take, and I send it to them, and we go over, and I screen share, and I'll do it now. Jerry, you said you were talking about the foot, right? Let me go to the foot.
Let's do it.
And we can, basically, I can just go to the patient and say, here, try this technique, or I could just give them a clip of it. Is it up yet?
Yep. I see the logo. Yep.
Logo, beautiful. All right. So let's go all the way down. And we can work on ankle stuff. So you were talking about Liz Frank. Obviously, that's not the talocrural joint, but I'm going to assume that she may have had some talocrural joint limitations. How can we introduce weight bearing and maintain an arch while we're doing this, and instruct the patient there? Now we could progress to a standing. So now we have a progression with 3 ways to do it: non-weight bearing, partial weight bearing, full weight bearing. Going into working on the foot. All right, maybe you can't teach her to directly mobilize where the Liz Frank is and the kind of that mid-foot area, but can we work on great toe extension? Can we work on calcaneal mobilizations, or whatever the case may be? I was working with a couple runners, so these actually worked out great. These bottom ones I showed you, who had some plantar fasciitis. Number one in the reason for plantar fasciitis, lacking dorsiflexion. Bam, you have 3 techniques to work on or actually 4 techniques to work on dorsiflexion. Great toe extension, very big to help stretch out that plantar fasciitis or plantar fascia, and work on that windlass mechanism. And then that calcaneal mobilization or subtalar. So these were the things I was able to, provide my patients and talk them through it, show them it, me physically show them it by angling it down and showing them whatever technique.
Mm-hmm.
And then, seeing how the patient's doing it and seeing if they're feeling what they're supposed to be feeling, and then just providing them with just some additional benefits. So if you haven't been doing that, I think that's a great way to add that manual component in there. Obviously, you and I cut from the same cloth, where we like manual therapy. We haven't been able to do it, but the way you and I, for the most part, kind of layer or blend our treatment, we do manual therapy, then we try to find or have the patient perform a self-mobilization technique that complements what we did on the table, to not only empower the patient so they can do it on their own, but also makes it more of an active approach.
Mm-hmm.
Again, one of those knocks on manual therapy is patients become too reliant. All right, well, I did what I needed to do in 2 to 5 minutes, and now I'm making the patient take some ownership in what they're doing, and now they can do it. Now, you said their retention of home exercise program isn't that high, which is fine, but I mean, we can only bring a horse to water.
Mm-hmm.
But if we can give them a technique that we can easily retest, and that patient can notice and see that benefit right away, they're probably going to be more inclined to do that technique rather than just having a telehealth session. Okay, do some bridges and clamshells and just some boring ass basic shit that, really what have you provided for them? They can do that on their own. And to be honest, no patient likes doing bridges. But what else can we provide for them? Again, a lot of patients, they're coming because they want that hands-on care, at least, or that component of it. Doesn't have to be the whole session, but we can't do that. Can we do something else? Can we provide them with some tools that they can perform on their own? I think that's the big benefit with the telehealth. And I think telehealth is going to be expedited. At least that's the hope with this pandemic. The laws and regulations. I mean, hopefully everyone saw how quickly, especially Medicare, who they suck, and don't want to pay for anything or pass anything, but they were actually pretty quick in saying, yeah, you can do telehealth and we'll pay for it, and you can do it on Zoom and you don't need HIPAA compliant, which honestly, on a recording tip like this, never made any sense to me why I can't do this. I need a HIPAA compliant software. Meanwhile, I could talk to somebody on a telephone and that not be HIPAA compliant. Where these laws make no fucking sense. And I know I'm cursing a lot, but
it's okay. We're explicit on
whatever
podcast.
Like, hopefully, we're drinking on it, right? We're 21 or older. Why, so like I was saying, hopefully a lot of these laws get passed through. We are both in New Jersey, and we have a compact law that we've signed and okayed, but we've been sitting, on our thumb, where not letting us be able to treat outside of the state. Again, why? If somebody has heard of me or has been referred to me and I want to be able to treat them, why can't I treat them? Or if they're out of state because they're on vacation, why can't I treat them? Again, all these barriers or perceived barriers have been knocked down because of the pandemic. So hopefully things get expedited here. And maybe that patient who didn't want to pay, those cash pay clinics didn't want to pay $100, $200 or whatever you charge. Maybe this is a way to keep them on, and maybe they don't need an hour. Maybe this is a great way to have a follow-up session where you're just checking in with the patient for 20 minutes for those more independent patients who just need to be cued the right way and don't need to come 3 times a week. I don't think most patients need to come 3 times a week anyway. But I think this is going to be good, or this will be a good thing as things evolve in just different ways to not only help our patients, but when you're owning a practice, different revenue streams, different ways to offer. And like we were talking in the previous podcast and we touched upon today, hopefully you're coming out of this pandemic, with extra, another skill set. How have you been able to adjust your business model or just business in general, to adapt to this, and not just hold out that, all right, it's gonna pass. All right, yeah, it probably will pass and it is gonna pass, but that doesn't mean we need to just rely on that. Use this time to be progressive, as much as you can. Obviously, we're being reactive, but knowing this, how can we then be progressive to the next time something like this happens? We're in a better situation, or maybe you just want to not be tied down to always being in the clinic to treat, and maybe you just want to treat at home a little bit. I think this will open up a lot of areas, and not just orthopedics, but how about peds or just consultations? I mean, the possibilities are endless with being able to use now telehealth or teleconsults or whatever you want to call it, moving forward. So
yeah,
I know I was talking for a while. My piece there. But yeah, Jared, what else? I don't know if you have any things on encouragement, pain science, what else you've been able to do or add to the value here.
Yeah, as actually just going into what you're about to say, and I always say the most powerful thing that we can give as therapists is some form of education, and that can be easily done over text messaging, calling, and definitely telehealth or virtual or Zoom sessions or everything like that. So, I always like to use my manual therapy time, whether it's like 5 minutes to 15 minutes to sometimes 20, 30 minutes, as a, 2-for-1 special. Is I'm educating as I'm doing it. So
you're talking as you're doing the technique.
Yeah, it's never quiet. Yeah, there's a little, shoot the shit sort of moments where it's like, hey, how was your weekend? And yada, 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 and those sort of things. And, but then we're like, talking about how things are going and, giving advice, presenting some research if it's need be. I try not to get too much into the weeds of that. But I can be done, via telehealth, and I'm doing that with my clients and stuff. Is, you know, a lot of these people, and if you know it, and we talk about central sensitization and chronic pain sort of things, is there's a lot more going on, biopsychosocially, what's going on with their stress levels. I get a lot of teachers right now, and God bless them all. I hope they all get raises after this. All the shit that they have to deal with, like converting everything online, and then they have all these parents, and then they're chasing after all these kids. And from what I see, they're all unfortunately, high stress individuals and those sort of things. So, just being an ear for them to, vent about these sort of things as I'm like, how's the day going? All right, well, let's do a self-mobilization technique as we're doing it. So, that's kind of what I've, evolved to, is more of I'm watching them as they're trying to talk. Some clients can't walk and talk at the same time. It's like they're either doing the exercise or they're talking. Ideally, we try and do both. That's why it's nice with manual therapy. It's like, well, I can talk and I can do the hands-on, and then you're just there to listen. Versus, there's been times where I've, talked, and even when they're on the bike, it's like their brain's focused on the exercise so much. But definitely use this as a time to educate clients about their status, their condition, those sort of things. And if they're making gains outside of the actual clinic, it's something to highlight. I would say all our telehealth clients are making progress. So it's like kind of good to kind of show them, again, especially also for that chronic pain client, that, sometimes these chronic pain clients feel the need to have something done to them. If you talk to them long enough, they've had chiropractic for all their life. They get, regular massages. They've had physical therapy in and out and those sort of things. And, if you've converted them to a telehealth kind of approach, this is kind of a good time to kind of bring that up as almost as a reflective piece of, hey, you're making gains. We're talking about things, and, no one's touched you in 2, 3, 4, 5, 6 weeks. So, there's things like that, that, you can talk about. And, I try not to anymore. And I haven't done it with telehealth, where I used to have extensive pain science conversations, like way too long. We had a podcast about it. It was like 30 minutes.
Yep.
Probably, people wanted to stab themselves after my talks, but, you can use it to that. I feel like, all right, I can't do as many exercises as I want with that person. I can't do hands-on. Maybe I can educate them more, but don't get into the weeds of talking their ears off for 30 minutes. Make sure it's interactive. That was something I failed to do early on. They got to communicate as much as I communicate, but that's,
I said we all have. We've all been there. I think it's important to allow yourself to be a beginner at something, and now we're erring on the side of more being experts. But there were times when we tried a lot of this stuff and we failed at it. We lost patience for it, whatever the case may be. So
So that's the fun about it. And then this was the fun about this whole situation, was I thought I needed to treat people in front of me. I've given tons of advice over phone, text messages. I think I was 3 for 3 for diagnosing foot fractures over either a text message or a phone call prior to all this. Nice. It's kind of cool. It's like, use Ottawa foot rules, send me a picture, this and that. I'm like, I think you broke your foot. And I'm like, oh, wow. You can do things, virtually or without being in, there. So this has forced the evolution of, wow, I can make some gains far away. And as you were saying, like, something I thought was like, I've, high level active individuals and they travel, 5 days a week and those sort of things. And I'm like, all right, yeah, follow up with me, as your week goes by and those sort of things. I'll see you in a week or 2 weeks. And I'm like, barely hear from them. And now it's just like, oh, maybe I can get them in their hotel room,
Yeah,
once,
no.
twice a week. So, yeah, it's definitely, use it as an opportunity to grow versus, again, just wait for
I think I think you said something great, which wasn't. I don't think was really going to be on our talk here, but um, the fact that you diagnosed, via text and phone calls, and granted, this was prior to telehealth, but hopefully this shift into telehealth and hopefully the catapult into it being, I don't want to say more mainstream, but at least more of an option. Hopefully that wants therapists or leads therapists to becoming better at diagnosing, better at understanding these rules. That yes, we basically just gloss over them in school, but how to really implement them.
Mhm.
Not maybe be as nervous, because I think a lot of times newer grads, students, even clinicians practicing several years, they forget about the auto anchor rules or these clusters that, yeah, they maybe aren't surefire, but at least they point us in the right direction. And something that we discuss in our lumbo-pelvic course is one of the biggest, I guess, tools that lie in our favor in terms of likelihood ratio and being able to diagnose is our clinical judgment. Like that's ranked pretty high. I think it's like a 19.2 or something like that. Granted, I think that's for cancer diagnosis, but we shouldn't discredit our knowledge in clinical diagnosis, and the information's out there. But you need to be able to recognize mechanisms of injuries, differential diagnosis, what other pathologies could it be, using, like you said, auto anchor rules, auto knee rules, things like that to help hedge our bets. I think that's only going to help with our ability to diagnose and not just always refer or feel the need to refer out for an X-ray or MRI, or refer to a doctor and things like. Let me rephrase that: refer to a physician, and I guess really empower us to empower the patient. And you could come see us. We're just as viable option for you guys. So yeah, I'm also looking for, speaking of patient education, and I wish I queued this up, but you said something again that it was off my radar. I have a few books, but one is a back book. You were talking about patient education and pain science and things like that.
Mhm.
These are great times too, where if you have ebooks, and like I said, I apologize I can't find it for your reference. I'll continue to look through it, and if not, I'll at least we'll put it in the show notes, right, Jerry? You handle that. We could put the link
Yeah.
in the show notes or something, right?
Yeah.
For everybody, where
Post.
I wouldn't suggest send the patient the whole book, because they may just get lost in it or totally lose. But you can send them video links or sections of a book on back pain and things like that. I know you and I both have the Adrian Lowe series. This other ebook, I forget the name of the author, but it's a back book, which just kind of breaks down back pain in a real simple way for patients, where you can utilize this and send this to patients, especially those chronic pain patients or psychosocial patients, those patients with a lot of yellow flags. I mean, this is a great time if you have these resources, to send it out. If you don't have these resources, reach out to me and Jeremy. We'll be happy to send it to you. And if we don't have it, maybe we know somebody who does.
Mhm.
But yeah, I think this is a time needed where we get to really expand on our skill set.
Yeah. Um, Absolutely. I think, yeah, again, you can, the thing is, making lemonade out of lemons. I think this is a good opportunity for all of us. So, we want to talk about any more other techniques or anything? Like, I like the ebook that you had there. Kind of showed a lot of
Yeah.
video wise. But
Let me see here. Where'd they all go? I have my upper. Did I close out my upper one? I might have to reopen that one. Give me 1 second, guys.
I have an upper one. Here we go.
I should send you these books anyway, just for your reference.
Actually, wait, hold on.
All right, here we go. Got it.
Well,
Screen share.
Yeah. All right. Just gonna put up one.
All right. Still getting the hang of this technology stuff, guys. Still working on it. See, we're all a work in progress. All right. So, so this is the lower extremity ebook. A little explanation on just some concepts. This is really made for PTs. But I mean, you can give it to patients. A lot of people are smarter than you think, or at least some of them are. But you could always just tell them to skip over the research stuff. And then really what they want to know is the meat and potatoes. So there's a standing posterior glide. I try to come up with techniques that patients can easily do, or a PT can describe for a patient. And I didn't try not to make it too complex here. Mm-hmm. That one, I mean, a patient can put their foot on an ottoman, on a chair, whatever the case may be. Just gently pull down. Bless you.
Thank you.
Gently push down, and you're getting a posterior hip glide. Going to help with hip pain, squatting, maybe low back pain. If you have performed a posterior glide or any type of hip glide on a patient before, this is a nice option for them. Long axis distraction. This is a little trickier. I mean, you're going to have patients order bands. And I recommend my patients do. I have them here. I order them in bulk, and, I sell to them at cost, where I'm not trying to profit off them. Like you, Jeremy, I'm here to provide them with a service to make them better. So, I provide them at cost. I try and get them on sale. And that's something they can do. I have a black band there. I should have used a different color band so you could see it, but I have a black band there around my ankle, long axis distraction. Teach the patient that. Have some indications where you can use it for, and then, improving glute med strength as well. Performing this type of mobilization will improve that. So you and I always talk about layering or blending treatments. If you perform a inferior hip glide or a posterior hip glide, well, we're improving glute med strength. Well, what can we do afterwards? Have the patient perform some hip exercises, whether it's bridges, clamshells, or maybe something a little more advanced, lunges, squatting, something like that. So now we're layering our treatment. We have a nice flow and reason of why we're doing manual therapy. It's not just so the patient can be passive in it. It's so we can accomplish these neurophysiological changes going on. Mm-hmm. Lateral hip glide, same thing, black bands anchored down. Somebody at home could put it on a stair banister or a dining room table that's nice and heavy or something. Same glide with hip flexion incorporated now. Another posterior hip glide, this time in supine with some overpressure of a band. Same thing here. Mm-hmm. So you guys get the idea. I don't want to bore you going through all this stuff here, but let me just show you the spine. That's a good one too.
And most of this is on your website, right? I'm pretty sure it's on your website.
Yeah, I have these 3 books on the website. When people come by, I'm actually patients. I just get into. I'm trying to revamp that. That's another thing I'm working on, trying to revamp where they might not be on the website for long.
Yeah,
I might.
I know between me and you,
I'm trying to market them differently, and I have a platform.
Yeah, between me and you, we've posted a lot of these, or some of these. I know I try to put up some self-mobilizations on my Instagram. I know I've seen it on yours.
Yeah, if you guys scroll through our Instagrams, a lot of this stuff is there, or you could just reach out to us and we could supply you with some information. But yeah, between the two of it. Oops, sorry. So which one's this? The spine book. So different variations, high press up to target upper back, or the upper low back. And then we have different segments. And really all you're doing is just readjusting your hands for that. We have a, kind of a unilateral rotation, kind of like a quadrant test press up. How the patient could do it standing with a strap, so it's assisted. They get a little bit more pressure through it. Lateral glides. I'm sure everyone has their patients do these, but how can we do some other ones? Hopefully, these give you some ideas. Combining those lateral glides into extension and or flexion. Got Britzel here, kind of getting hips, low back, mid back. Obviously, I think most people have seen something like this. And then this is obviously a favorite. We go over this in our course, Jer.
Mm-hmm.
So a lot of different ideas here, indications why you would use it, stuff like that. So, that's kind of what you can offer your patients is just it's something different. It doesn't always have to be exercise or education, but they're having something that a crick in their neck, inflame. What do we want to do? We just want to bring them back down where they're not as irritable. So really, it's really what I'm trying to accomplish there.
And as you were saying, that neurophysiological effect to decrease the pain so they can do those other exercises. So, I mean, that's a big reason why we do manual therapy in conjunction or adjunction to everything else. So,
or educating patients on different philosophies. This just popped in my head, Jer, as you were saying that. Having a patient who's just, doing foam rolling to the IT band for 30 minutes. How can we just make that where they don't have to spend 30 minutes doing it? Well, if you maybe work on some other areas, hip strengthening, that alleviates the pressure on the IT band, or if they're doing just rolling up and down on their spine, well, can we make it a little more specific? What are we trying to accomplish? Why are you just rolling up and down? Are you trying to accomplish extension? Are you trying to accomplish rotation? Are you trying to accomplish a combination of extension and rotation? You should then have your patient do a mobilization with the foam roll of extension and rotation, or thoracic extension or thoracolumbar extension, targeting that specific area that we intend to address, and not just have the patient bridge up and roll up and down on a foam roller. Mm-hmm. Yeah, it might feel good, but what are you really accomplishing? How can we get more specific with our treatments? How can we educate the patient? Okay, what you're doing is great. Let's make a little tweak and just make that a little bit more effective for you. Spin it that way, so we're not poo-pooing the patient making their best effort because they watch somebody else or is a different provider. We don't need to bash anybody, but say, okay, that's great that you're doing that. I'm just going to make a little adjustment, and this is why, and we're trying to be more specific and target, this impairment, which is going to lead to an improvement in this symptom, and, explain that to them while they're doing it. You create that buy-in, hopefully they do it, and it doesn't take them 30 minutes to roll out their whole body, because now we're just focusing on the one or two areas that we need to do. I think that's important.
Yeah, I think it's huge. And especially as we start to get into specifics of sports and those sort of things, again, you can just, extension over, for thoracic spine, but, sometimes it's rotation and those sort of things, for a pitcher, those sort of things. So, yes, and if you tie that into the education and show that you understand what they're going through and how it's related to their functional deficits, whether it's sport or picking up their kids or those sort of things, they'll all tie in, and they'll believe you forever, whether it's distance or in the clinic. So now those are some awesome techniques and advice. And I don't think anything else that you want to bring up there, Brandon?
No, I think we've ranted enough. Anything else on your end, Jer?
No, I think that's good. And if you need any more techniques or anything like that, or you're having, there's certain times where I get like, I would say a lot of times I had to jog my mind. I'm like, how could I possibly teach this to someone else? And, give it a couple minutes and those sort of things. And you're probably able to, but if you're having a tough time figuring it out for a particular client, or you had a particular manual technique that was super beneficial for the person, but now they're removed from you, reach out to us. between two of us, I'm sure we can help you think of something. You know, I say, get those super bands. Those can really help out things. But yeah, we're always here for you guys. At Manips and Sips at free Instagram and Facebook. Me personally, I'm at The Decent Doctor and at Trifecta Therapeutics. Brand's at Think Like a Fellow and at Pursue PT Now. But yeah, I hope you guys learned some good techniques and, thought about some things to continue your manual therapy virtually. So, well, cheers, everyone. I don't know if Brandon, you got anything else left to say, but
No, you closed up well, man. Appreciate it.
all right.
And we'll see you guys next time.
All right, see you guys. Bye now.